This is Wei Chen from Cleveland Clinic. My talk is graphic, so please prepare yourself. Out of respect to my colleagues, I do things a little bit differently, but I do respect everybody's differences. So what I'm saying right now just simply represents our own opinion and experience here at Cleveland Clinic. All right, so as previous speakers have already established, liposuction is a well-established treatment for lipedema, and we now, after all day, we know how to diagnose lipedema. Liposuction is also a well-established treatment for lymphedema. So people may not realize that lipodystrophy is a prominent, important component of lymphedema. And contrary to popular belief, you don't just see lipodystrophy in late lymphedema. You actually see it early. It's just that in the early portion of the disease course, they may not be clinically obvious. They're insidious. So even when they're there, you may not realize that they're there. So a patient like this, clearly anyone can tell there's already elephantiasis, lymphedema with prominent solid disease component or lipodystrophy. Now, there are differences between lipedema and lymphedema liposuction. Let's go through some of them. First of all, lymphedema-induced lipodystrophy is significantly more rigid and therefore much more difficult, much more non-yielding. It takes a lot more effort to get them out. And I echo Dr. Gutowski's comment about PAL. Power-assisted liposuction is a must. I've also tried everything, ultrasound, laser, water jet, whatever. I think for regular cosmetic liposuction, you really have the luxury to pick whatever you want, whatever works better for your marketing purpose. But for lymphedema liposuction with those dense fibrotic tissue, you have to go with PAL. Nothing else, in our experience, worked. And for lymphedema, there is a decreasing window of opportunity that you can effectively intervene because as their fibrosis builds up, your ability to retrieve these tissue decreases with time until you get to a point that liposuction now no longer works. Now the only thing that will work is your scalpel. You need to do radical excision, which is substantially more invasive, and therefore for lymphedema liposuction, the procedure is time sensitive. The earlier, the better. And lipedema-related lipodystrophy is characteristically fluffier, and they're so much softer. As I just said in my last talk, when you use PAL on lipedema fat, it's like a hot knife cutting through butter. It's actually so much easier compared to lymphedema liposuction. So it's interesting how when we see lipedema and lymphedema coexisting, having lipedema is actually considered a favorable factor because we know that these fat are almost never going to be as rigid as those patients having pure lymphedema. It's almost as lipedema is a protective mechanism preventing severe fibrosis, which is very interesting. Here again, I echo Dr. Gutowski's point about the need to remove skin. Whereas currently in lymphedema surgery and lymphedema debulking surgery, the dogma or the most common practice is to not remove skin. For some reason, many of my respected colleagues believe that the skin will shrink. I always tell them if the skin would completely shrink away, then why do we do body contouring procedures for patients with massive weight loss? Why do we do tummy tuck for ladies who have 5 kids? Apparently, skin do shrink, but they don't completely shrink. So another issue is when the skin after liposuction is left intact, you don't remove them. This is what you get. Because when you apply compression garment, it's difficult to compress evenly without folding the skin on itself, strangulating the skin, causing skin necrosis, and also leaving all the skin excess behind creates a lot of potential space. Then you put the patient at risk of hematoma and seroma. So we propose the immediate, following liposuction, immediate skin excision. We call it the flying squirrel liposuction technique. And so
traction away from...
Truthfully, when you see a flying squirrel sign, you will recognize it. You really don't need to measure it, but when we submitted the study, the reviewer insists on a metric. You have to give us a centimeter. So we told them, yeah, between 4 to 5 centimeters with the skin under maximal traction from the fascia, that's considered a positive flying squirrel sign, and we recommend skin reduction. But truthfully, when you see this, you know if you leave that skin behind, it's a problem waiting to happen. There's so much dead space, high risk for hematoma, seroma, and the skin, it's difficult to create even compression. And even if somehow the patients got lucky, the skin completely contracted down, you're gonna get uneven, wavy contour. All right, this is graphic. So this is what we do. Can we play the video, please? So we do the double ellipse technique to estimate the amount of skin to be removed. And then for extra safety, we do, if this bothers you, please look away. We do the tailor tacking for extra safety so we don't over-resect. And so this is a very safe technique. It allows us to precisely remove the amount of skin excess that needs to go. So after we do that, we mark out what we're going to cut out. I still have 4 minutes, so it looks like I will make it. All right, so now we cut everything out, and don't worry, the staple closure is only temporary. We're plastic surgeons after all. All right, so this is another benefit of flying squirrel technique. This is what I meant when there is a diminishing window of opportunity for us to intervene effectively. This patient already developed elephantiasis, and when we say fibrosis, this is what it looks like. For this patient, so much of her dense fibrotic tissue just didn't want to come out with liposuction. So once we open, now we could use the scalpel to directly excise all the bad tissue. You can see all the fibrotic tissue encasing her great saphenous vein. You can see a little bit of the vein at the bottom. This patient would also characteristically have chronic compartment syndrome because her deep fascias are pathologically thickened and her muscles are not allowed to expand with exertion. So these patients would always tell you, with exertion, I get that dull ache in my leg. That's chronic compartment syndrome. And okay, here I show the release. Those of you who were in my operating room yesterday saw what it looked like, saw what a chronic compartment syndrome looked like, and saw how we treat it. You can see how the muscle herniated out through that gap in the fascial opening. And now we close everything, and we don't need to use the drains, no drains, because all the dead space have been eliminated. And it's okay to go very thin. We aim to normalize. So shin is supposed to be bony, which means that you shave everything down to 2 or 3 millimeters. Ankle is supposed to be bony. The top of your foot is you're supposed to see veins and tendons, which will require surgeons to be very, very aggressive. Going aggressive does raise the risk of complications. So it's a very delicate balance. If you undertreat, it's safe, but you're not getting the best possible result. If you're aggressive and thorough, you will get superior result until you are too aggressive. But in general, if you are experienced, it's okay to go thin. And this patient will have a bony shin for sure. Case presentation. This is a lipedema patient, and we remove. So we treat leg and thigh separately. Leg meaning below the knee, because of how aggressive we are. We would prefer to, I understand there are many surgeons who would treat leg and thigh simultaneously. We prefer to treat leg and thigh separately. So each of our procedures is about 2 hours in and out, and but we're very thorough. After 4,550 cc removed, please play video. And now without measuring, we clearly have a positive flying squirrel sign. So we're going to trim off this much skin. And this is after the skin removed. And you can do this single stage. Very, very safe. So that's on the table result. This is another lipedema patient. You can look at her before result on the table immediately afterward. And you can see that in this patient, only 1 minute left. She needed removal of both upper arm and forearm skin. Another patient in the leg below the knee after 2,900 cc removed. This is a lymphedema patient. This is another lymphedema patient, 2,800 cc removed. We prefer to put the scar behind the arm, which is, for the most part, patient will rarely see that scar. This is a lipedema patient, 2,800 cc removed with flying squirrel technique. Another patient, this is a lipedema patient, I believe, yes. And both upper arm and forearm skin removed. Another lipedema patient, and now her left arm is smaller than her healthy arm. She wants a cosmetic arm lift and liposuction. All right, I run out of time. I'm going to just click through. Hypersurgery, liposuction first, and LVA later. This is for a lipedema and lymphedema patient. This is that patient I showed before, elephantiasis. We can still treat her instead of doing radical excision, and we can greatly improve her condition. Okay, lastly, does liposuction damage lymphatics? Here's the good news. No, it doesn't. We already knew that from 2004, but the evidence back then wasn't as good as what we're going to present. We have now image-based evidence. This is that patient that I showed you before. You can see on the ICG lymphography, not only that her lymph drainage didn't worsen, it actually improved. So liposuction, we can only describe our experience. In my experience, enhanced lymph drainage. And to date, we have 839 cases. I'm only going to include our 2-year Cleveland Clinic experience, 131 cases, 42 cases being lipedema, and those are the volumes removed, and post-op infection was 0, hematoma seroma was 0, 0% required transfusion. We have skin necrosis in 3.8%, all lymphedema cases, and minor dehiscence, 8.3, again, all lymphedema cases. We had 0 lipedema patients having complications, and I will conclude here.